So this is chapter 11, Caring for the Postpartum Woman and Her Family. This begins on page 370 in your book, and we consider the postpartum period immediately after birth, and then it lasts for about 6 weeks. Ensuring safety for the mother and infant. So safety is a common fear after the birth of the baby, especially if you're in a hospital setting. So there's a lot of different things, and if you've already been with me to the unit, you have seen these things, but we'll talk about them as we go there as well if you haven't been with me. But ID bands are placed on the mother, one other person, and those match the baby's bands. Those are put on immediately after birth. And then they also have transponders that will close doors, lock stairwells, things like that, elevators. And then there's also visitation policies as well. So misidentification of newborns. So remember in Skills Law, we talked about the ID band. So remember I said 2 bands on the baby, 1 band on the mom, 1 band on another person of the mother's choice. And these are looked at every time the baby is picked up from the mother's room or taken back to the mother's room. Okay, so think about misidentification sometimes of babies. If you weren't the one that took the baby back to the room, you need to make sure that's the baby before you take it away. Okay, so look on page 371. You can see that focus on safety box there on that page. Now here's another thing. Infants are only transported in a bassinet throughout the hospital. They are not carried outside of the room and they're in someone's arms. That's by the staff or the parent. So anytime the baby is transported anywhere outside of the room, the mother's room, they should be in the little rolling bassinet. And then remember what the universal code is for an infant abduction and in a hospital setting. So if you remember what that is, it's a code pink. So if you ever hear a code pink, that means that a baby has been abducted and they're looking for that baby. So now I'm going to talk about what we're looking for when we begin to assess the mother right after delivery within those first several hours after delivery, especially those first 24 hours. It's critical. We want to know what is considered normal changes after delivery and what we would be concerned about. So you can look on page 372. Table 11-1 shows you this rapid assessment. So it breaks down all these things we're gonna focus on today, and it shows you what's considered normal. Then it shows you on the right-hand column what would be causes if it was abnormal and kind of things you would be looking for. Now, we're going to start with vital signs. Every hospital is different as far as how often they check vital signs. Normally, it's every 4 hours once the patient is stabilized. So that's pretty common that it would be every 4 hours that we're checking. So let's start with temperature. The temperature should be between 98.6 and 100.4 degrees. Now remember, sometimes the mother can have uncontrollable shaking within those first 2 hours after delivery, which is considered normal because the body's been through a lot. Okay, medications sometimes can cause that as well. So just make sure you're watching for that, and that is normal. Just make sure you're keeping a check on that temperature. The pulse, so normal may be between 50 and 70 because of the elevated stroke volume. You want to watch for tachycardia because that can indicate, it could be caused by prolonged labor, but it could also be an indication of blood loss, elevation in temperature, hemorrhage, or infection. So we really want to pay attention to the heart rate because that's going to be one of the first signs that we see for that hemorrhage, okay? Now, blood pressure. The blood pressure should be back to baseline in the first trimester, so we're going to compare it to whatever her blood pressure was in that first trimester. Decreased blood pressure is a late sign of hemorrhage. So we're not, blood pressure is not a good indicator in the early signs, okay? Because it's usually going to remain normal, even though they may be hemorrhaging. That's why we focus on the heart rate. So once the blood pressure begins to change, that's a late sign of hemorrhage. So we really want to catch it before it gets to that, okay? Preeclampsia can develop in the postpartum period. So you're also going to monitor for signs of elevated blood pressure. Remember, that would be over 140/80 or 140/90 even. We're going to watch for that, especially when the patient is experiencing edema, if they're having headaches, vision changes, things like that. We're going to watch for, especially when their blood pressure is elevated. Respirations. Monitor for signs of pulmonary edema, even a pulmonary embolism. So we would be looking for a sudden onset of tachypnea, any abnormal lung sound she may have, shortness of breath, chest pain. If she becomes anxious or restless, those could be signs of pulmonary edema. And then pain, obviously, we're looking at the fifth vital sign. So a lot of times they will experience what we call after pains. Those are caused by the uterine contraction. So remember, the uterus is trying to contract back down to normal. Okay, so it's trying to contract back down to its normal size and get rid of all the blood and everything. So involution is that process of contracting back down. So she may experience after pains, usually about 2 to 3 days after delivery, that she will have those after pains. And if she's breastfeeding, when she starts to breastfeed the baby, that can also cause those after pains to occur because that causes contractions of your uterus as well. So remember that about the after pains, and the process of the uterus contracting down is called involution. Now, medications is listed here. So a lot of times it's going to be mild analgesics. Ibuprofen, that can be administered if they're having some discomfort. Usually, if they're going to breastfeed and they've been having discomfort, those after pains, you can administer that ibuprofen about 30 minutes before they begin breastfeeding, and that will help. And then testing in the postpartum period, if not performed previously, the mother's blood type is going to be determined, her RH status, a rubella titer. Remember, that's very important about immunity to rubella, so that titer will be drawn if that wasn't done previously. Hemoglobin and hematocrit may be done to assess for anemia as well. So concise postpartum assessment guide. So this is important, and I put this here because this helps you remember what to assess, okay? So if you look on page 374, flip over one page, and it shows you table 11-2. This is called the bubble he assessment. So it helps you remember what is important and what to assess during that postpartum period. So bubble he is what we're talking about. So B stands for breast. Now I'm going to break it down what we're going to assess under each category, okay? So for the breast, first we're going to determine if the mother is breastfeeding or if she's bottle feeding. That's an important thing to know before we get started so that we can make sure we're assessing properly, make sure we're giving proper education. So the breast should be soft. There's not going to be much change within those first 24 to 48 hours following delivery. She is going to be producing that colostrum initially. Remember, colostrum is that liquid gold. By the third day, the milk is starting to come in, and the breast should begin to feel firm, okay? By that fourth or fifth day, somewhere between that fourth and fifth day, if she's breastfeeding, the breast should feel firm before feeding. They will feel really full, and then after feeding, they will soften because then the milk supply is gone at that point. If she's breastfeeding, you want to assess the nipples for cracking or bleeding because that could indicate some issues with the baby latching properly. So you want to watch for that. If bottle feeding, we want to educate on engorgement. Now remember, we talked about engorgement during our skills day. So engorgement is just that swelling and tightness of the breast due to the milk production, but it's not being released out, okay? Usually this will last for about 72 hours after delivery, and then it will spontaneously resolve. Usually it takes a day or so, sometimes up to 24 to 36 hours it can take for it to spontaneously resolve. But it's important that she does not stimulate the milk production or express that milk to be released. Even though that will feel better, if she stimulates that milk to be released, then her body will think that the baby is eating and it will produce more, okay? So her breast will feel very heavy and tender during this time. Just help her remember that not to express the milk, not to stand under a hot shower, but she can use ice packs. We talked about cabbage leaves. A lot of times people will use cabbage leaves to kind of ease that discomfort, and then it will resolve within that 24 to 36 hour mark. Now, the U part is uterus. So remember where I said involution, that's that process by which the uterus is going to return to its normal non-pregnant state. So involution is that shrinking back down. And we assess the fundal height. We're looking at that fundus, we're feeling it. Where's the fundal height? We're looking at the consistency, the location of it. Is it displaced, to one side? We want to know about that. Is it midline, okay? Remember, we want it to be firm, not boggy. And we do want it to be midline, meaning in the center of the abdomen. So we document that as midline. It's even with the umbilicus or umbilicus. And remember, it's either +1, +2 above, or -1, -2 below, depending on the location. Now remember what the reason would be if it's displaced to the right. What did we talk about in skills lab if the uterus, if we're feeling the fundus and it's displaced to the right? Remember, I'm giving you a second to think about it. Remember, we talked about her bladder may be full. So if it's displaced to the right, you want to help her to the restroom, tell her to empty her bladder, and then have her lie back down, and you can assess it again, and it should be midline at that point. Okay, and we want to do that fundal massage if it's boggy. So fundal massage would be just massaging that fundus, and we want to make sure it's going to firm back up, because if it's boggy, remember, she's at risk for hemorrhaging, and we want to really make sure that that uterus is going to firm back up. Okay, look at page 375, table 11-4. It shows you where the fundus should be located depending on how many hours after delivery she is. Okay, so you kind of see there, 1 to 2 hours is going to be even with the umbilicus. Then after that, it starts to change. Okay, so kind of look at that and determine, where she is in the delivery process and where you're going to feel it. That's page 375, table 11-4. Then look over to 376, and that is figure 11-5. And you can kind of see the fundal heights on her when you're looking at the fundal heights based on the days. Now, this is important for you to remember. The most common reasons for subinvolution are retained placental fragments or infection. So those would be the two most common reasons for subinvolution, meaning that the uterus is not contracting back down like it's supposed to. Remember, involution is the process of it contracting down. Subinvolution means it's not doing that process. It's staying where it is. It's not contracting down. So those two most common reasons would be retained placental fragments or infection, which obviously can cause hemorrhaging. We want to really monitor that. There is a video in Blackboard to watch for a fundal massage. So you can look under the lesson 3, I believe it's module 3 folder, and you can see that video for a fundal massage. So make sure you go and watch that so you see exactly what she's doing in that video. Okay. All right. So the first B, we've done BU. Now we're down to the next B. It stands for bowel. We want to assess for bowel sounds. We're assessing for the presence of hemorrhoids, which are very common after delivery. Constipation can occur because of decreased muscle tone. She may be dehydrated. Maybe she has discomfort or is resisting the urge. So constipation is very common. A lot of times they'll have a stool softener prescribed for that in the postpartum period. The next B stands for bladder. Following a vaginal birth, spontaneous voiding should occur within 6 to 8 hours. So the body's going to start getting rid of all that excess fluid. So she should be able to spontaneously void within that 6 to 8 hour mark following delivery. So you're going to monitor, you're going to measure in the beginning, we're going to measure. So if it's less than 150 milliliters per hour, we want to assess for urinary retention, because there may be this decreased urge to void. Maybe something happened. Maybe there's an alteration in her voiding reflex following delivery, and that can cause her bladder to become distended, which, remember, causes her fundus to become displaced, which can lead to bleeding because her uterus is not able to contract back down. So we're really trying to pay attention to her output, her urinary output. And if you look over on page 377, table 11-5 shows you the nursing assessment. It shows you signs and symptoms that you would be looking for and interventions that you would be doing as well. Now, L stands for lochia. So we are going to assess the type of lochia, the amount, the color, the clots, the odor. Remember, we talked about the lochia. I had that laid out when we did the skills lab that day. So, and we talked about the change in the lochia. Okay, so I have a handout that I'm going to give to you when we come back to class, but I'm going to explain this. And then once you have your handout, you can go back and listen to this again to look at the actual pictures I'm going to show you. Okay, so lochia rubra. This is the bright red blood, possibly some small clots as well. When I say small clots, normal size would be about a nickel size or even a dime size. Okay, so that would be normal size clots if you're looking at clots and helping the mom determine if those clots are normal. So about a nickel or dime size. So lochia rubra is bright red blood, possibly some small clots. Usually you're going to see this about 2 hours following delivery, up to 3 days after the delivery. Now, persistence past 3 days is indicative of continued bleeding due to retained placental fragments. So that's why it's important to document what it looks like, the type, whether it's rubra, serosa, alba. That's what we're going to talk about. So if that rubra, which is that bright red, continues past that 3rd day, then we know that something's going on. Okay, we need to do further assessment. So that's rubra. The next stage is called lochia serosa, which is a pink brownish discharge. This lasts from about the 4th day, and it can last up to 10 to 14 days following delivery, so that you start to see how it's changing at that point. Then lochia alba, this is a yellowish white discharge with little to no blood, so it's starting to really change. There's not really blood anymore in it. That starts around day 10 to 14, and it can last up to 8 weeks following delivery. And if you look on page 378, figure 11-6 shows you what, remember I showed you that in lab that we talked about the amount, whether it's scant, light, moderate, or heavy, or you can call it severe. Okay, so remember the vivid image of what I showed you in the lab as well. Now be mindful that the flow of lochia will usually increase when she gets up out of bed to ambulate, when she's breastfeeding, when she stands up from either lying in bed or sitting in bed. She may feel a gush of blood, okay, because the blood will pull in the vaginal canal when she's lying down, okay. So when she goes to stand up, she may feel a gush of that blood. And so just kind of keep an eye on that. Remember, we always ask how long she's had the pad on, so we know kind of a time frame. So remember those things when we're looking at the lochia as well. Episiotomy, this is when we're doing a perineal assessment. Okay, so remember the episiotomy, that's going to be the incision made in the perineum between the vaginal opening and the anus during childbirth. And a lot of times it's going to be done to help get the baby out. Okay, we used to, I think I said this the other day, we used to do this routinely as far as everybody got an episiotomy. But now the American College of Obstetrics and Gynecology said we only need to do that if there is an absolute need for it. Okay, so we're not doing it routinely anymore, only if it's necessary. So when we're looking at the perineum, we're going to look at obviously if there's an episiotomy or any laceration, any tearing, okay. We're looking at the vagina, we're looking at the perineal area, we're also looking at the rectum. We're monitoring all those things. We're looking for swelling, bruising, were there any injuries? Usually the episiotomy edges, if there is an episiotomy, those edges will become fused within about 24 hours after birth. So you're kind of monitoring those edges, making sure it looks good. Then if you look on page 379 in your book, table 11-6. Now this is kind of a little acronym to help you remember how to assess the perineal area. It's called RETA. So R would be for redness, E, the first E for edema, the second E for ecchymosis, D is for drainage, and A is for approximation. So RETA kind of helps you remember what you're looking for when you're assessing the perineal area. And remember the other day we discussed the sitz bath. I showed you the material and how to set up the sitz bath for comfort. Ice packs obviously can be given as well. Usually that's for swelling within the first 12 hours. A dermaplast spray, we talked about that. You may see that in postpartum or mother baby as well. Witch hazel pads can be given, though. All of that would help her be more comfortable. So that's the episiotomy. H stands for Homan sign. So this would be discomfort behind the knee when the foot is dorsiflexed. Okay, so when the foot is out, the leg is out, the foot is dorsiflexed, the patient will have pain or discomfort behind the knee. And this would be a positive Homan sign, which would be indicative of a DVT. Okay, so we're obviously looking for that. Now, it is a common screening tool that's performed. The Homan sign is a positive screening tool, but it's not 100% accurate because a a positive Holman sign obviously is indicative, but only about 50% of the time they're going to have a positive Holman sign. Okay. So sometimes they can have a DVT and not have a positive Holman sign. So we do want to perform that, but remember, we have to make sure that we're looking at other things as well. Okay. Other indications. If you look on page 379, there is a prevention box where it says what to say. On the right hand column, there's that prevention box there for ways that you can help her prevent that DVT. So obviously getting up as soon as possible after delivery, whether it's a vaginal delivery or a C-section, you want to help her get up as soon as possible and make sure that she is moving around. Okay. And then E is emotional status. Is she bonding with the baby? Does she appear sad or depressed? We're going to talk more about that as far as depression, postpartum depression, and that sort of thing later on in this chapter. But how is she emotionally? Is she getting frustrated? Is she trying to breastfeed? Has she named the baby? Is she holding the baby? Is she making eye contact with the baby? Or is the baby laying over in the bassinet over to the side and she's not really doing much or interacting with the baby? So really watching for those bonding things with the baby, okay? Okay, so that is bubble he. That is a way to help you remember the important things to assess on the mother, okay? Now for this, I have a little handout that I will give out regarding all of these changes. I'm not going to go over every single one here on the recording, but I do have a handout that I will give to you when we come back to class, and this will explain these different systems and what we talk about with the different changes in that and how we assess these and what we're looking for. Okay, so just know that there's going to be a handout for this that we will discuss. Okay. Now, developing cultural sensitivity. So obviously we've talked a lot about culture and we have to be mindful of that. We have to understand what culture she is and, what type of maybe desires that she has. We have to do that holistic approach. We have to make sure that we are not imposing our culture or our beliefs onto her, but that yet we're understanding hers. Okay. And if you look at page 383, flip over a couple of pages to page 383. Developing cultural sensitivity on the right-hand side, you can look at these bullet points to help you understand how to do that. And if you flip over to page 384, there's two more at the top of that page. So look at those bullet points, page 383 to 384. That will kind of give you some idea on how to do that to be culturally sensitive in the postpartum period. Promoting recovery and self-care in the puerium. Let me say that again. Puerium, which is the postpartum period. Getting tongue-tied. So if you look here on this slide, this picture, this is a true representation of what a new mother feels like if you've ever had a baby. So let's look at activity and rest. And this is what we want to make sure we're explaining to the mom, we're educating the mom about in that postpartum period, because self-care is very important for her. A lot of moms do not do self-care ever. Even when your kids are older, you still don't do self-care. So it's important for her to understand that it's okay to ask for help. It's okay to rest. Okay, so let's look at this. Activity and rest. So obviously we talked about ambulating as soon as possible to prevent DVTs, especially if she had a C-section. We want to make sure she's getting up and moving. No abdominal exercises for 6 weeks. And then sleep deprivation is a common problem, but it is a serious concern. Obviously, we want to make sure that she's getting some rest, and hopefully she has someone there to help her. Even if she doesn't, it's important to let her know that it's okay to take breaks, to have the baby in the crib, safely in the crib. Okay, if she's getting overwhelmed and the baby's crying and she's tried everything she knows to do and the baby won't stop crying, it's okay to put the baby in the crib and safely in the crib. Okay, remember, nothing in the crib but the baby and the bulb syringe. Okay, and to walk out of the room for a few minutes and let her know that that's okay to do. Okay, nourishment. So she's going to lose about 10 to 12 pounds immediately after delivery. And then there probably will be around an additional 5 pounds lost over the next week because of all that diuresis, getting rid of all that fluid. So usually within 6 to 8 weeks, she will return to her pre-pregnancy weight if she had normal weight gain throughout her pregnancy to start with. Okay. She may need to continue an iron supplement if her hemoglobin is low. So that might be an option you have to explain to her as well. Elimination. So voiding, we talked about, should occur usually within 4 hours after childbirth. You want to really monitor if she's gotten close to that 6 to 8 hour mark, but we want to see it within those 4 hours if possible. And then you should encourage her to void every 4 to 6 hours. And she may not feel like she has to right at the beginning, but that's why we want to encourage her to continue voiding. We're going to, it said in your book that eyes and nose are assessed for the first 24 hours, but every facility has a different policy. So it all depends on where you're at and where you're working. So we will discuss that policy at TIFF Regional when you're there with me. Now, if she's having difficulty voiding, she may need a catheter, even if it's temporary, as far as maybe even an in and out catheter, but she may need that if she's having trouble voiding. So we talked about constipation earlier. So obviously drinking plenty of fluids can help with that. Ambulation can help with that. Eating foods high in fiber, and then using the stool softener as well. And then perineal care, she is at an increased risk for infection if she has any kind of lacerations. So cleaning the perineal area is important. Using that sitz bath, the peri bottle that they use to clean the area, changing her pads frequently. All of those would be educational things that you're going to provide to her to make sure she's preventing infection. And then if you look over on page 385, you'll see that patient education box there about perineal care, and you can look at that in your book on page 385. Okay, so care of the postpartum surgical patient. Let me say that again. So we're going to talk about different reasons they would have surgery in the postpartum period. So permanent sterilization, we're talking about a tubal ligation. So we discussed this previously. Remember, we talked about that as a method of permanent birth control. A lot of times that may be performed at the same time as a scheduled C-section, or even if she has to have an emergency C-section, they may do that at the same time. So when we look at the care of the patient after a C-section, we're going to complete that bubble HE assessment that we talked about earlier. You're going to give them strategies to prevent that DVT. She may have those. She may have the stockings on, the compression stockings. She may have that intermittent compression devices on. So whatever she has, just help her remember what that's there for. And then once those things are removed, she can begin to get up and move around. And bonding is important during those first few hours after a C-section. So we want to monitor that, make sure that she's able to bond with the baby. Recovery from anesthesia. This is going to depend on the type of anesthesia used. So we talked about the different types, whether it's a spinal, an epidural, sometimes general anesthesia, but obviously that's going to be whatever type of anesthesia she had is going to depend on what we do. And we do want to encourage ambulation because of that DVT issue as soon as possible, especially when she has sensation return to her lower extremities. She may need to sit on the side of the bed when she first starts getting up to prevent that orthostatic hypotension. And we want to make sure we explain that to her as well, that she may feel dizzy. And so give herself a minute to sit on the side of the bed. Abdominal distension. This can result from delayed peristalsis. So only ice chips or small sips of water should be given until you hear those bowel sounds. And that's why it's important to assess for those after she has surgery, whether it's a C-section or tubal or whatever it is. And then ambulation is encouraged once again because it'll help with those gas pains as well that she may have after that. Urinary system. So in drilling Foley for about 24 hours after C-section, once again, that depends on your facility policy. That can be different wherever they are. And she should be voiding within 6 hours after removal of the Foley. So once that Foley is taken out, you're monitoring her, and she should be voiding within 6 hours after that on her own. And then care of the incision. There's different types of dressings that may be used. They may have island dressings, but really what you're looking at, and a lot of times they'll have steri-strips as well. So what you're looking at is the dressing intact? Do you note any leaking of blood or bodily fluids from the incision? So you're monitoring the incision site just like you would any other surgical site, okay, for that dressing to be intact and any drainage that you may see, redness, anything like that. Breastfeeding. So benefits to breastfeeding. Look over to page 387, and you'll see box 11-2 there for the benefits of breastfeeding. And you can see the benefit to the mother and the benefit to the infant. Now, let me say this before we go any further about breastfeeding and bottle feeding. Remember that this is the mother's choice, okay? We give educational information, but we do not try to push our opinion on the mother. If she chooses to breastfeed, that's her decision. If she chooses to bottle feed, that's her decision. We want to support her in whatever decision she makes and give her educational information regardless of whatever decision she makes, okay? So you'll see that box on page 387. Then you will see contraindications. So look at these bullet points. The top of page 387. Actually, it starts over on the left-hand column of page 387. So infants with galactosemia, mothers with active TB, if she has HIV, okay, if she has Hep B or C, if she uses illicit drugs, and the list goes on. So I'm not going to read every single one. You can read those. But that would be the only contraindication to her not being able to breastfeed, okay, where you would say, no, you cannot breastfeed, okay? So make sure you pay attention to those bullet points. Now, lactogenesis. Let me explain what this is. This begins after delivery of the placenta. Remember, the baby's born, the umbilical cord comes out, the placenta is delivered. So lactogenesis is the process of the breast secreting milk due to that release of prolactin and oxytocin. So basically your body is saying, the baby is out, the placenta has been delivered, it is now time to produce milk. Okay, now is the time. We've got to get ready now. So this is just the process of the milk being produced, the milk being secreted because of that prolactin and oxytocin release. So the letdown reflex is when the milk moves into the ducts so that it can flow from the breasts. So this feels like a tingling sensation immediately before or during breastfeeding. So you'll feel this letdown reflex, especially when the baby starts to cry and it's time for the baby to eat. The mother may feel this tingling sensation as the milk begins to come flow into the ducts to actually be released, and it's called the letdown reflex. You can look on page 390. It says Nursing Insight on page 390. And you can look at the ways to assess for that letdown reflex. And we talked about colostrum. That's the liquid gold, and it's produced usually for the first 24 to 48 hours following delivery, and then the mature milk begins to produce after that. And remember, I said it's supply and demand. So the more the baby eats, the more your body's going to produce, okay? And look over on back a page to page 388 and look at the patient education box. So you're going to make sure you're teaching her how to care for her breast during this lactation period, okay? Breastfeeding success. So all this research they have done has said that initiating breastfeeding within 1 hour after birth optimizes your outcomes. Not saying you won't be successful, but it just optimizes your outcomes. And you can look on page 389 for those optimizing outcomes. And we're going to talk about that breast crawl. That's when the baby is placed skin to skin on the mom immediately after birth. So that skin to skin interaction, what we also call as kangaroo care, is very important to help facilitate breastfeeding. Usually hospitals will have lactation consultants. So TIF Regional actually has 2 different lactation consultants that go around to each mother and talks to them about breastfeeding, encourages them as far as if they choose to breastfeed, they have a desire to breastfeed, she will work with them and help encourage them to continue on, that it does take time to learn and for her and the baby both to kind of get in the swing of things. There are also community resources. La Leche is an organization that provides resources as well. Now, here's what's important to know about breastfeeding. It should not hurt. Now, when I say that, there may be some slight discomfort or some tugging, but it should not hurt, like be really painful, okay? So if she starts feeling a little bit of discomfort, she can, remove the baby off and readjust the latch. So when I say the latch, that means the way the baby is latched on or attached to the mother during the breastfeeding process. So the latch is what we want to look at to make sure the baby is getting the right, using the right sucking pattern to get the milk out. Okay, so if she's having some discomfort, she can take the baby off and kind of readjust and relatch the baby. So on page 390, you can flip over to page 390 and look at box 11-3, and that lets the mom know when the baby is getting ready to eat. Okay, so these are cues to when the baby is ready to eat. Okay, we talked about that rooting reflex. That's one of the things the baby does. Okay, and then you can look at the what to say box, assisting the mother whose infant will not awaken to breastfeed, and then collaboration and care, that other box on page 390, if the facilitating breastfeeding and the mother with a physical disability. I'm not going to read both of those boxes, but you can look at those on your own. Both of those are on page 390. Okay, so let's continue talking about breastfeeding. So the main concern is my baby getting enough? How do I know my baby's getting enough? So obviously we look at infant weight gain. So it is normal for the infant to lose weight after birth, okay, but it should not be more than 7 to 10% of their birth weight. So they're going to lose some, but that's why they keep a track on weighing the baby every day. So they're monitoring for what percentage of the birth weight the baby has lost. So if it starts getting close to that 7% mark, they're going to start monitoring that. We don't want it to go over 7 to 10%. So how do we make sure the baby's getting enough? Well, frequent feedings. Now we're talking about breastfeeding. Okay, so keep in mind, we're still talking about breastfeeding. So frequent feedings every 2 to 3 hours. You want to encourage mom to feed on each breast for 15 to 20 minutes. Not on one side only and not on the other side. So if she starts on the left side, she's going to feed for 15 to 20 minutes on the left side. Then change the baby over to the right side and feed for 15 to 20 minutes. Okay. Not just one at a time. We've got to do both every feeding, okay? The next feeding, she can start on the right side, 15 to 20 minutes, move to the left side for 15 to 20 minutes, okay? Also, you're going to monitor the number of wet diapers a day. So the baby should have 6 to 8 wet diapers a day, and that's also another way that you can see that the baby's getting enough, okay? So positions for breastfeeding, you can see all of the positions here. The cradle hold, there's a cross cradle hold, there's a football hold, and there's also side lying. So you can look at page 391. Figure 11-10 kind of shows you those different positions. So A would be the cradle hold. The cross cradle would be basically the opposite side of the body. The football hold is figure B. You're holding it like you would see them carrying a football running down the field, okay? And then C is the sideline position. Now, what I want to say is to be very careful with the sideline because moms get tired and get sleepy, right? We want to lay down. If it's 2 a.m, we want to lay down. And feed the baby because we're exhausted. So you have to be very careful with that sideline position because of accidental suffocation. So be very, very careful if she's going to do that. Explain that to her. Breast engorgement. So remember I talked about this previously. This is when the breast can become hard and painful and swollen because of overfilling, and that can last for about 24 hours. So usually that's going to occur between that 3rd and 5th day of the postpartum period. Okay, so this can happen from infrequent feeding or maybe ineffective emptying of the breast. Now this is what we're talking about if she's breastfeeding exclusively. Okay, so if she's not feeding the baby every 2 to 3 hours, or if she's not completely emptying the breast. Like I said, you've got to feed on both sides or you're going to become engorged, okay? So what you want to do, now if she is breastfeeding exclusively, we want to remove the milk, okay? So we can feed the baby, we can pump the milk, okay? If it's not removed, the body will start decreasing that milk supply because remember it's supply and demand. So if that milk is not removed out, once they become engorged like that, if she's breastfeeding, okay, that means we need to get it out, pump it, or feed the baby, or whatever we need to do, because our body will stop producing. The supply will decrease. Now, Ice packs can be used for engorgement, but this is important if she's breastfeeding. After the feeding to relieve that discomfort. Because what's going to happen if you put them on before the feeding? The breast milk the supply is going to decrease, okay? So remember, put the ice packs on after breastfeeding if she's exclusively breastfeeding, if she needs some relief from the discomfort, okay? Breast milk storage, flip over to page 392, table 11-7. I'm not going to go into every single detail about this. They usually give the breastfeeding moms this information as well. They'll give them a little handout about this and explain how their breast milk can be stored, especially if they are pumping, okay? But just look at that, kind of know what you're supposed to do, but I'm not going to go into detail about that. It is important, I will say this is what's important. If she's going to pump and try to bottle feed the baby, it's important to wait at least 3 to 4 weeks if she can, because we want to ensure that the breastfeeding has been well established. Because obviously the baby, it's much easier to bottle feed because the milk flows freely out of the nipple from the bottle, okay? And the baby has to work a little bit to get the milk flow started when breastfeeding. So it's important to establish that good breastfeeding routine first. So if she can, to wait 3 to 4 weeks before she starts pumping the milk and feeding the baby a bottle. Okay. Now, all that's about breastfeeding. Now, I want to talk about formula feeding. Okay. Now, remember, this is the choice from the parent, what to do. Okay. There's a lot of different types of formula out there. You want to make sure it's iron fortified with cow's milk. Okay. Unless the baby has an allergy to cow's milk. So you just look at all the different types. You want to choose the one that's iron fortified with cow's milk. Okay. There's a lot of different ways that it can be given. So there's a powder that's usually mixed with water, and it tells you how to mix it up on there. There's a concentrate that you also mix with water. And then there's a ready to feed. So these ready to feed bottles, all you have to do is screw the top of it off, screw the nipple on, and it's ready to go. Very convenient, okay? Very convenient. But this is what's important. There's several things that you have to do to educate the parents, okay? Do not warm bottles in the microwave. These can create hot pockets in the milk that will actually burn the baby, and you may not realize it even when you're testing the temperature of the milk, okay? So do not warm the bottles in a microwave, ever, okay? Now, a lot of times you're going to have to tell the parents this, especially if they have one of those ready-to-feed bottles like they give them in the hospital. So they take the top off, they screw the nipple on, they start feeding the baby. A lot of times they will want to save that bottle and use it again if the baby only ate, 15 cc's out of it. Well, we have to explain to them that any unused formula after the baby's finished with that bottle has to be thrown away, okay? Now, if it's the disposable, obviously, bottle, you throw it away. If they're reusable bottles and nipples, you want to make sure they're washing those with warm soapy water, okay? But they has to be discarded. They can't use that same bottle and formula again, okay? Because there's bacteria that builds up in between the feedings. So we want to make sure they're pouring that out or tossing the bottle. They're washing the bottles, washing the nipples, okay? So listen to this. On day 1, the stomach of a newborn is about the size of a cherry. So that's not very big. So you want to make sure that you're educating them also on avoiding overfeeding the baby. So initially the baby is not going to have very much. They're not going to drink very much. So obviously as they start getting bigger, they will, okay? So usually in that first day or day to 2 days, so 24 to 48 hours, they're only going to eat about 15 to 30 milliliters. And they'll eat that about every 3 to 4 hours, okay? They should have 6 to 8 feedings in a 24-hour period. So as long as they're staying on track with that, the baby should be getting all it needs, okay? So just make sure you're educating them on those things when bottle feeding. Promoting family and infant bonding. We talked a little bit about this earlier. Bonding is just that relationship that we talk about between the parent and the infant, and it's very, very critical during this time for the infant survival and also proper development. So that's what we say when we say bonding. Now, attachment refers to the tie that exists between the parent and the infant. So this is recognized as that feeling that binds one person to another. So bonding is different. Bonding is different from attachment. So I just want you to understand what that is. Bonding usually begins when the pregnancy is confirmed, and then it continues throughout the child's early years of life. Attachment is just that tie that automatically exists in that relationship. Okay. So transition to parenthood. Education is very important during this time, especially if they're going to prenatal visits. We want to make sure we're helping them understand what's going to change after the baby's born, and then even in that postpartum period as well. So flip over to page 395. You'll see those bullet points in the right-hand column of how we can help them transition to parenthood. For the mother, there are 3 phases. It's called taking in, taking hold, and letting go. And if you look over one page to page 397, table 11-8 shows you where she should kind of be in those phases. So taking in is the first phase, usually the first couple of days. Then taking hold is the second and or third day. And then the first 2 to 6 weeks is that letting go phase. Okay, so you can read that on page 397. Then you can look at back one page to page 396, and that turquoise box is the assessment tools. And this is what you're looking for that attachment between the mother and the baby. Okay. And then for the father, now, if he's present during the prenatal visits, if he's in the delivery room, all those things have really contributed to the dad's feeling better able to bond with the infant as well. So those things help. Hands-on care, letting the dad do skin to skin, all those things can help that dad bond with the baby as well. Now, sometimes there can be interruptions to bonding. So stress is the main factor that's going to interrupt the bonding time. It could be finances. It could be somebody having to go back to work. It could be the care of other children. It could be lack of support. A lot of other things can contribute to interruptions in bonding. So we talk about the NICU. So when the baby has to go to the NICU, that obviously interrupts the bonding between the mother, father, and the baby. So the baby having to go to the NICU. Frequent visiting is encouraged when the baby's in the NICU. If the baby can be touched, that's encouraged. If the baby can have kangaroo care, that's that skin to skin, that's encouraged as well. Okay, so just think about those things that can interrupt or interfere with the bonding and how to overcome those things. Sibling adjustment. This is a big thing as well. A lot of times siblings may feel jealous. They may have behavioral regression. For instance, maybe they were potty trained and they were doing wonderfully for months, and then all of a sudden they're wetting their pants again. They're not going to the restroom. So they may have some regression in their behavior where they previously were further ahead. Okay. A lot of times it's important to prepare them ahead of time, be honest with them and prepare them, let them know they can help, especially after the baby's born. They can help do different things if they want to help. That's a good way to include them in the care. And you can look over on page 397 at the bottom right, and it goes over to the top of page 398. Those are just some strategies that you can do to educate the parents on how to help the sibling adjust. Emotional and physiological adjustments during this postpartum period. And this is where I mentioned earlier we were going to talk about postpartum depression and things like that. So I want you to understand the difference between what we call the baby blues or postpartum blues. The difference between that and postpartum depression and postpartum psychosis. And it's very, very important that you understand the differences in these three. Okay. So during the first 3 months after delivery, those are very vulnerable for the mother. Okay. A lot of times it's due to insecurity with how the care she's given to the baby, if she's being a good mother. Okay. Sleep deprivation, a huge thing. Okay. Maybe she has minimal support, hormonal changes. All of these things contribute during that postpartum period to her emotional state. Okay. So let me tell you what the difference in these three are. And like I said, it's very important that you know the difference in these. So the postpartum blues, this is very, very common following delivery. This would be considered a normal reaction after delivery because of that abrupt withdrawal of all those hormones that she's had in her body during the pregnancy. So symptoms you may see being tearful, crying frequently, having mood swings, insomnia, fatigue, anxiety, maybe difficulty concentrating, okay? Usually you're going to start seeing these symptoms within the first few days in that postpartum period, and then they usually will subside over the next several days. This is the key with postpartum blues. It does not affect her ability to care for herself or her baby. Let me say that again. This is the key with postpartum blues. It does not affect her ability to care for herself or her baby. Okay? Postpartum depression usually appears around 2 weeks following delivery. So she may have had the blues up until then. 2 weeks following delivery, you may see something more significant. Okay? Symptoms include sleep disturbance, guilt, fatigue, feelings of hopelessness and worthlessness. So see the difference. They may also have suicidal ideations, okay? Harming themselves, harming the baby. So when you start seeing these changes about that 2-week mark, proper evaluation and assessment is necessary, okay, for the mother. Postpartum, and then at that point, when you're thinking of depression, let me go back to that. When you're thinking of depression, she's not caring for herself or her baby at that point. That's the difference that I want you to see, okay? With postpartum blues, she may be tearful, she may be, hormonal, she may have some mood swings, but she's still able to take care of herself and her baby. Postpartum depression, she's not, okay? Postpartum psychosis. Now, this is rare. This is a rare condition, but if it happens, it is an emergency situation. It includes what you think of as psychosis, delusions, hallucinations. She may become agitated, inability to sleep, just bizarre and irrational behavior. If you see that, that is an emergency. Okay, so be watchful of that as well. Now, physiological responses to the emotional events. Obviously, postpartum tiredness and fatigue are considered normal responses to labor. It's important for her to rest when she's able to. And it's okay to accept help from other people, to ask other people for help and say, hey, can you sit here and watch the baby for, 3 hours while I take a nap or whatever it is until it's time to feed the baby again. So help her know that it's okay to rest, that she's not being a bad mom if she needs to rest. Okay. Postpartum discharge planning and teaching. So remember, I've talked about all the information that's important for the mom to know about herself and her baby before she leaves the hospital, and we have limited time to do that. So let's first talk about promoting maternal self-care. Remember, I talked about, we're not good at taking care of ourselves. We're good at taking care of other people, but not so much ourselves. So usually in the hospital after delivery, a normal vaginal delivery is in the hospital for 24 to 48 hours. So that's about the max amount of time you have to do all your teaching, okay? C-sections may be there for 72 hours. 3, maybe 4 days depending, but 72 hours thereabouts. So that's all the time you have to do teaching for them. So we need to include things like how to bathe your baby, how to feed your baby, breastfeeding, perinatal care, what physical activity you can perform, resting, expected emotional changes, how to prevent infection, signs and symptoms to look for when for bleeding, for hemorrhage, for infection. There's a lot of things that go into this, right? So here's what I want to focus on, her lochia. We talked about the changes and how it should be changing over the different postpartum weeks, the days and weeks, okay? So instruct her to report if she has numerous large clots, if she starts noticing foul smelling or green discharge. We need to know those things. So point that out to her. For her incision, if she has a C-section incision and if it has steri strips, she should not take off the steri strips but allow them to fall off on their own. She should also be looking for any signs of infection. Her bowel and bladder, continue good hydration. Maybe she needs a stool softener to continue once she's even discharged until her bowel movements are regular. Pain management. NSAIDs are usually the choice that are going to be used for pain management. And then sexual activity. We want to discourage sexual activity for the first 6 weeks in that postpartum period to allow your body time to heal. And then you have to discuss with her, usually at that 6th week, or even before she's discharged, or even during pregnancy. It depends. But especially at that 6-week postpartum visit, they're going to discuss contraception moving on from there, okay, and what her choice is at that time. So flip over a couple to page 401. And the very bottom, it says postpartum discharge teaching the danger signs, box 11-4. That would be really important to focus on what you're looking at and what you're teaching her to monitor for when she needs to contact a healthcare provider. Okay. And then patients with special needs during postpartum. So an adolescent that's just had a baby, remember we talked about this earlier, the things that we educate them on, not the way we care for them, but the things we educate them on are going to be a little bit different for an adolescent versus an older woman, maybe an advanced maternal age woman. Okay, remember I said that was over 35 years old. Okay, so for an adolescent, the supportive environment is critical. Do they have a support person? Do they not? Okay, you want to provide resources available to help them. They may need a lot more education regarding self-care and infant care. Remember I told you about a student that I took up several semesters ago to postpartum, and she had a 17-year-old that did not have any support with her there, and she did not know how to take care of herself, didn't know how to take care of the baby. She didn't know she could ask for a new gown because she got something on her gown. Okay, so sometimes they require a lot more education depending on what's going on and if they have a support person there with them or not. So for adoption, obviously you want to allow time for the emotions of the mother giving her baby up for adoption. You want to provide compassionate care for her and that compassionate environment for her. And then an older woman. Now remember I said this is over 35 years old. There's an increased risk of pre-existing conditions and maybe increased health problems that they may have. Emotional support may be necessary. So there may be a lot of other changes and things that you have to discuss with a woman that's older. Okay. Community resources. Now every community is different as far as what's available in your area, so it's important to know the availability and the resources that are there in your particular area. But a lot of times there will be support groups where moms and families can come and share their experiences and their challenges and kind of come together with one another. Home visits may be done in some areas. That's to follow up with the mom and the baby to perform those assessments to make sure that everything's going well. Telephone follow-up, a lot of times they will, someone from the doctor's office will call 2 to 3 days after discharge to just kind of follow up with the mom and see how she's doing. And then outpatient clinics. This would be an option for facilities that do not offer home visits. So ones that don't send people out to the home to follow up after delivery, an outpatient clinic might be a good option. And then knowledge check. So we're not going to do this right now. We're going to do this. We're going to play this game when we get back to class together. So just disregard this for now because that's what we're going to do when we come back to class together.